amyloid position. A neuropathology, so we look for senile plaques and neurofibrillary tangles. So senile plaques are the amyloid plaques that are usually extracellular. Neurofibrillary tangles are the tau deposition that's intracellular. So this is the senile plaque. This is the tau. I think I'm running out of time, so I'll try to go quickly over the remaining slides. So I'll just show you this. So this is the pathological diagnosis of Alzheimer's disease. It follows the A, B, C classification, where A stands for amyloid, B stands for BRAC, which is a classification for the tau distribution in the brain, and C stands for CIRAD, which is another method to study the amount of amyloid deposition in the brain. So the higher the degree of amyloid, of CIRAD, of B, the higher the likelihood of, or the higher the certainty of Alzheimer's disease. So cognitive symptoms correlate more strongly with the burden and distribution of tau, the neurofibrillary tangles, and definitely the presence of co-pathologies. This is something that we commonly hear in cognitive neurology, co-pathology. So people with Alzheimer's disease who also have Lewy body deposition may have worse symptoms than people who have Alzheimer's, like amyloid and tau, without Lewy body. So co-pathologies can sometimes synergistically contribute to the cognitive decline. So this is the continuum that we talked about earlier. In the management of Alzheimer's disease, it's an art. We need to avoid harm. The first step is always to clean the medications. This is this is a list of medications that we usually screen people for. Like, we make sure that if they don't need them, we omit them. Prevention is very important, as we mentioned earlier. Now, in the different stages of the disease, for MCI, the only medication that's currently available is the amyloid targeting antibodies, the new medications that are in the market. We will have a dedicated webinar in the future, inshallah, talking about these medications. Now, in the mild dementia, we have the old medications that we have, like cholinesterase inhibitors, but we also have the new medications, the amyloid targeting antibodies, aducanumab, lecanemab, and donanemab. I forgot to list donanemab here. Aducanumab is no longer in the market, but lecanemab and donanemab are in the market, not yet available in the kingdom. And then once we go to the moderate and severe, you cannot prescribe amyloid targeting antibodies, but you can still prescribe cholinesterase inhibitors and memantine. Now, these are the different medications with the different side effects profile. They're generally safe medications. The only red flag, I would say, for cholinesterase inhibitors is arrhythmias or heart blocks because they do increase the PR interval. Now, there is no clear recommendation, but I usually do an ECG 1 month after putting the patient on the full dose of cholinesterase inhibitors. Now, the new medications, we have lecanemab in the Clarity trial, and we have donanemab in the Trailblazer trial. It's very important to know that these medications are not cure for Alzheimer's disease. They are said to make the progression slower. We cannot say this confidently because we still do not see how people do after 18 months, but we can see that there is some difference between those who received the treatment and those who did not. It's very important when you read the trial, whether for lecanemab or donanemab, to know what is the primary endpoint. So for lecanemab, the primary endpoint was CDR, Clinical Dementia Rating Scale, that we will be talking about later on in the workshop, which is a pure functional assessment scale, while in donanemab, the primary endpoint was a composite score that's taking that's taking both cognitive and functional aspects into consideration. Now, we cannot talk about amyloid targeting antibodies without talking about ARIA, which is one of the major concerns that we have when prescribing those medications. So although those medications are bringing some hope for people with disparate disease, but they come with a cost, they come with a risk. And the risk is imaging-related amyloid abnormality. Although the name sounds subtle, like it's only imaging-related, but they do come with symptoms. So they can present with seizure, headache, coma, decreased level of consciousness. So this is something that we need to take into consideration, and it was reported in every amyloid targeting antibody. Again, that's the trailblazer, and that's the primary endpoint that is looking into ADAS-Cog, which is a cognitive assessment tool, and IADL, which is a functional assessment tool. And again, ARIA is still there and it's still reported, it's significant, and that's why those medications should be prescribed only to the right population, only in the right time, and only in the right setting. You need to be confident that they have Alzheimer's disease, and you need to be confident that it's really Alzheimer's disease, not something else. You need to make sure that they don't have contraindications to start these medications. You need to have access for serial MRIs. You need to have access for serial clinical assessments. You need to inform your patients that these medications are taking through IV infusion, so they would need to come frequently to the hospital to receive this medication. So these are things that we need to keep in mind. And they are only given in the MCI and mild dementia. You cannot give it to people with moderate and severe dementia. And an emphasis on the evidence of amyloid presence, and an emphasis that you are using the right tools to assess their cognitive status and their functional status. So these are the three questions that we need to answer, and in the workshop, we'll go over them again. Okay, I think according to the agenda, I'm not sure if we're having a break now, or are we having a break, or we can proceed with the next? Okay, I think we can proceed with Dr. Lubna. So, Dr. Lubna, if you may share. I see some questions, so I have two questions here. What is the best cognitive assessment tool for illiteracy? We will talk about cognitive assessment tools later on in the workshop, but this is a very important question. Are there any other questions that you would like to ask? If you can, maybe at the end, before the break, if you have any questions, you can put them in the chat and we can answer them later. Now it's my pleasure to present Dr. Lubna Al-Bassam. Dr. Lubna is a consultant geriatric psychiatrist in King Fahd Specialist Hospital, and she will be talking about the neuropsychiatric symptoms of dementia. So, Dr. Lubna.
Thank you, Dr. Just let me share my screen, please.
I was able to see your screen earlier, but not now. Maybe you can try again.
Are you not able to see it now?
لا.
Let me try. Are you able to see it now, please?
Yes.
Okay, perfect. Hi everyone, Assalamu alaikum. My name is Dr. Lubna Al-Bassam. I'm a consultant geriatric psychiatrist. And after the long journey that Dr. Ra talked about it, I will go to somehow similar but yet different journey of having dementia and all the burden of living with the dementia or care providing with dementia. And one of the most challenging and burdening things about having a dementia or Alzheimer's disease, dementia of Alzheimer's disease, is having the neuropsychiatric symptoms of the neurocognitive disorders, or in other words, dementia. Sorry. Okay. So Just simply, the neuropsychiatric symptoms are the non-cognitive symptoms of dementia that Dr. Ru'a have emphasized a lot. Another very popular name of it is the behavioral and psychological symptoms of dementia. Uh, Lately, people are going through changing the term of dementia into neurocognitive disorder. So you will see this term being used more often. And behavioral and psychological symptoms are being also used interchangeably with the neuropsychiatric symptoms of dementia. Those are abbreviations that I will just go through quickly. Neuropsychiatric symptoms, NPS, behavioral and psychological symptoms of dementia, and then NCD will stand for neurocognitive disorder. The DSM is a diagnostic and statistical manual of mental health disorders. The latest version is the fifth text revised, and as I said, dementia is just a former name of neurocognitive disorder, so it will be used together. Okay. So this is the criteria of diagnosing neurocognitive disorders or dementia for us as psychiatrists. And one of the part of diagnosis is having actually behavioral symptoms. And you can see that there's a specification of behavioral symptoms or without behavioral disturbances or symptoms. And then you can go on and specify more of those symptoms are related, for example, for mood symptoms, irritation, apathy, or psychotic symptoms, other symptoms. So just for quick numbers, for the sake of numbers, how much this is burdening. So like almost by the year 2050, according to the the WHO, there will be more than 100 million people having a neurocognitive disorder or dementia. Nearly almost all of them will have some part of neuropsychiatric symptoms throughout their illness. And the management of this dementia is usually very complicated throughout the progressive course of a disease with the non-cognitive symptoms or the neuropsychiatric symptoms. It's very challenging to manage. I will be talking about medications that are used to manage the neuropsychiatric symptoms, and my colleague, Dr. Modi, will talk about the non-pharmacological symptoms later on. But I will tell you that it's a big challenge for the most expert people in dementia is to deal with the neuropsychiatric symptoms, and that they keep on changing in etiology and manifestation throughout the course of the illness, which could be lasting for a long number of years and sometimes decades. So those are neuropsychiatric symptoms. If you undetect them or unmonitor them and then untreat them, they will cause the patient and the caregiver extreme or substantial distress, and they lead to earlier need for long-term admission. So they will have detrimental consequences if they weren't detected, monitored, or treated. And the quality of life for those people and their care providers, as well as their clinicians, is extremely challenged by this. Patients with untreated neuropsychiatric symptoms, they will have way poor quality of life compared to other patients. They will have a more rapid progression of their disease, and they will be placed in a structured living environments or in institutions, long-term institutions, earlier in the course of their disease. Care providers of patients who have neuropsychiatric symptoms and they're not being treated, they are at a very high risk of dissatisfaction, burnout, and even clinical depression. And there are variable studies that sometimes go into telling you that care providers, they will have a 60 to 70% chances of developing depression throughout providing the care for those patients through years. And there's a big literature about how to take care of the care providers. So for example, just for a quick, I'll try to make it as easy and basic for everyone. I understand this could be complicated for people or not aware of a lot of psychiatry manipulations or disorders. So just an example, like imagine a patient or has having Alzheimer's disease or dementia, and they're suffering from delusions, and those delusions are extremely distressing. For example, just like imagine the idea that you have this fixed, unshakable belief that you are being look somebody that was going to harm you and that you are at a risk of being killed, for example, or that you're being followed by a gang or whatever, like FBI investigations. It's so distressing. And those delusions will increase a lot of other symptoms like restlessness, prone to wandering. The patient will become stubborn and way more noisier, and they will have a way higher risk to engage in physical aggression or, on the other hand, in self-harm. They will be needing a significant amount of supervision. Sometimes even one care provider will not be enough, which will lead to caregiver burnout and increase the healthcare costs. It's a wide range of symptoms. Most of them are including depression, including neurovegetative signs and symptoms, which include eating, sleeping, fatigability. Irritability is a common sign. Anxiety, sleep changes, that is very structural sleep changes are very common in Alzheimer's disease. Psychosis, including delusions and or hallucinations. Agitation, which is a very burdening symptom and has a wide range of explanations. I will be talking about it later on. Aggression, that could be verbal or physical. Apathy, which is lack of reactivity or initiative and blunted affect, which will be usually you will see it later on the disease, not at the beginnings. Sometimes there's the other extreme of depression, which is elevated mood, or manic symptoms, which also can be burdening. And just bear in mind, throughout the course of the disease, these symptoms will keep on changing. So you might find a patient who are with a mostly depressed, and then they might develop psychotic symptoms related with aggression, and then later on they would develop apathy. So throughout the course of the illness, symptoms will keep on changing, and according to that, you will also change the treatment plan. Agitation, which is a very common symptom, as I said, could include just from being restless or requesting for help, or sometimes repeating questions, which could be very annoying for care providers. And if you don't answer the patient, they might get again agitated for not being responded to, screaming or vocalizations, repeating words, hitting, pushing, kicking, and then sexual disinhibited behavior is also common, and it's a form of agitation. I would just like to mention those two measurement tools that if you read the literature behind Alzheimer's disease or dementia, you have to be familiar with it. And those measurement tools are usually administered by physicians or nurses who are in direct contact of patients. Sometimes it could be administered by care providers, but it will give you an idea about what are the neuropsychiatric symptoms that are present, how are they responding to treatment, how are they changing throughout the course of the disease. And it's the most true common tools. I didn't mention other tools, not to really make it harder or more complex, but these two tools are very important for you to know if you're interested in dementia. The Cohen-Mansfield Agitation Inventory, the most commonly used one. I will talk about it and what kind of symptoms it covers, and then the Neuropsychiatric Inventory, that's easier to administer. And the Cohen-Mansfield Agitation Inventory, which you'll find it very commonly, and most of the studies or research studies are using this kind of inventory. It will be covering wide range of agitation, from physical aggression, like hitting, biting, kicking, pushing, grabbing onto people, or scratching, spitting, making physical, sexual advances, hurting self or hurting others, sometimes even just throwing things, tearing things, or destroying property, is all form of physical aggression. So physical aggression could be toward ourselves, toward others, and toward other objects. It could be just also repetitive behaviors. Physical non-aggressive behaviors like pacing, or just like without any purpose wandering around. And this is a very disturbing symptom for the care provider, where they have to give a lot of supervision and concentration and attention to the patients who are pacing around. They are at a higher risk of being lost in the way. For example, like if you are following the Saudi Alzheimer's Society, you will find almost every day a new report that they are putting throughout with the police help and them for people who are being lost. People are being very creative and finding ways to try to control this. For example, having digital watches, or sometimes even the air tags are used for people who are prone to just pace and without any aim wandering around. Could be also going to inappropriate dressing, or actually disrobing or undressing in front of others, trying to get to different places, hiding things and hoarding things. And sometimes it could be so disturbing to the extent that patients might have the extreme symptoms of even hoarding a lot of unneeded things. There's a lot of I think it's one of the interesting things that people talk about hoarding, because it's like it could stay on for years and increase over time. For hiding things, sometimes it could be very disturbing to the extent that patients might even like try to gather their feces and hide it in ways, or hide food, or hide sometimes and like any kind of material things. Sometimes intentional fallings, which could be disturbing as well. Eating, drinking inappropriately. Sorry, just let me remove that. And then handling things inappropriately, performing repetitive mannerisms or behaviors. So just general restlessness is considered as a physical non-aggressive behavior. Those other two parts that are covered by the Cohen-Mansfield agitation inventory is the verbal aggressive, where screaming and making verbal sexual advances, sometimes cursing, verbal aggression, and something that is common that we see with patients. And people are familiar with Alzheimer's disease. You will see patients who are saying inappropriate words or comments that you see when they are waiting, for example, in the waiting room or in your office. This is just a part of a verbal aggression. And verbal non-aggressive behavior, like repeating sentences or questions, or sometimes strange noises, complaining, being negativism, or just like trying to be able to have a repetitive and constant unwarranted requests for attention or help. And sometimes even that it's not meaningful, but they're just asking for attention. They would say sometimes words or sentences that doesn't really have a meaning, or that could be comprehended by the care providers. After that, the neuropsychiatric inventory that will cover other set of symptoms, including psychotic symptoms, most commonly delusions and hallucinations, very disturbing symptoms, mood symptoms, including depression, eating disturbances, mainly sleep disturbances with either fragmented sleep or difficulty to fall asleep is very prominent at the beginning of the illnesses. And then hyperactivity, where as we mentioned, a part of agitation, being irritable, being actually euphoric, and or being disinhibited. So those are actually two tools. You could easily use them in your clinic to track the behaviors that you're trying to treat throughout the course of a disease. So in many actually literature studies, they would tell you that neuropsychiatric symptoms are as common as up to 80 or 97% of patients of Alzheimer will suffer of those symptoms throughout the progression of their disease. And that's a huge number. And for a lot of times, the cognitive symptoms are not as burdening as the non-cognitive or the neuropsychiatric symptoms. It's extremely prevalent, going from apathy, which is very common in an Alzheimer's disease, to depression, aggression, sleep disturbances, and all of those other symptoms. So to the lesser extent, you would have those manic symptoms rather than to the upper extent they would have where people are dysphoric, depressed, apathic, or aggressive. How are these symptoms being presented in other kinds of dementia? Some vascular disease will have a similar pattern to Alzheimer's disease. Sleep disturbances is one of the most common symptoms in all patient groups. They also would have apathy and motor retardation common in vascular disease, depression, anxiety, irritability, agitation, and aggression. Cortical vascular dementia will have more apathy if you compare to the subcortical vascular. They will have more agitation or aggression. And Parkinson's disease or lower body disorder, you will have more of the psychotic symptoms, delusions, and the hallucinations at the illness presentation, which is somehow early in the disease, and sometimes even before the full before the full diagnosis of the lower body dementia or dementia of the lower body disorder. And sometimes it could be also complicated by personality changes, who people who are respectful, or people who are very resilient or well spoken, and then they start having changes in their personality. They will act strangely, they will say things that are out of character, they will dress in a different way, they will start having sometimes interests that are not common to their baseline personalities. For example, drinking alcohol, or sometimes being fascinated by gambling is very common in those personality changes, and also going to the spectrum of the psychotic disorders. Hallucinations is very dominant in the dementia of Lewy body, depression as well, more dominant than Alzheimer's disease. And sometimes those neuropsychiatric symptoms will help us or guide us to diagnose the right kind of dementia the patient is having, which could be very challenging. Delusions or hallucinations, again, are also common, as I just mentioned. It's more common than the dementia and the Parkinson's disease. Frontotemporal dementia, it's one of the, especially in, it's very common to have neuropsychiatric symptoms, especially in the behavioral variant of it. And you will see, as I mentioned earlier, significant changes in the personality and the behavior early on before having any cognitive symptoms. The higher rates of neuropsychiatric symptoms for a given are for a given severity of the dementia, meaning it is connected to how progressive the disease is. So in the frontotemporal dementia, compared to Alzheimer, you will have higher rates of delusions, disinhibited behavior, abnormal motor behaviors, and significant abnormal eating behaviors. Sometimes they would call it hyperphagia. They would eat huge amount of food, or usually request food for a lot of repeatedly, or they will be interested in eating things that are not suitable for eating, like mud or sometimes metal things. They would be chewing papers, for example, or other abnormal eating behaviors. Just not to confuse you with this, it's very complex. There are different guides all over the world of how to treat the neuropsychiatric symptoms, just because as simple as two reasons. It's very complicated and difficult to treat, and it needs a lot of studying further on to know how to treat it, because it's very challenging and difficult to treat. I just wanted to post this to see how much we have, and related to that, MOH, Ministry of Health, has in 2021, so almost 2.5 years now, have this protocol for the management of behavior and psychological symptoms of the dementia, and you could find it in the website of Ministry of Health. Why am I mentioning this? It's easy to follow. I will be going through it with you now. It's easy to follow, and as nurses, as general physicians, up to like well specialized medical staff, you will be dealing with it, and you will find patients who are taking the medications for it for a long time. So it's good if you, as long as you're dealing with elderly with Alzheimer's or other kinds of dementia, it's good to get yourself well oriented with those kind of medication. And this is where the guidelines will be helping us. So for the Saudi MOH protocol, they have used the multi-prescribing guidelines in psychiatry in the UK, which is very common, and those other guidelines. Those are one of the main international guidelines that are being used. I just wanted for you to mention it if you are interested to go into further reading of longer and having more specifications of guidelines of how to treat those behavioral or psychological symptoms of dementia. The protocol was evidence-based decision-taking tool, so there was a lot of most of the medication choices were given up to to the knowledge that we have at the time being and the studies that we have. It's regularly updated, and I will talk about the recent update in that and those guidelines to treatment those symptoms. But put in mind that those do not replace the clinical judgment of practicing physicians. Meaning, even if you have the guidelines telling you to use such and such, a medication such and such, the most superior is your clinical judgment and what kind of symptoms is the patient suffering from, and this will guide you to be able to customize the care plan to the patient's unique situation. Pharmacological interventions of the neuropsychiatric symptoms are necessarily even if the patient are showing a risk to harm others, or they're showing significant distress to the patient themselves or the care providers. Medication choice have to be proper when you are assessing the risk over the benefits. It's always advisable to identify, measure, and monitor the target symptoms, and then the adverse effect of the medication. And as I said, like, it's good for you to have a plan in mind. Just I will be talking about it, how to use it, an approach to describe the symptom, describe the circumstances leading to this kind of behavior, and then assess the severity of the consequences of this kind of behavior. For example, a patient with Alzheimer's disease who's going to in an unfamiliar place and they're unable to recognize the environment and the people around them, they might show anxiety. Later on, if a stranger talks to them, the anxiety will reach up to irritability, and then they might have a temper tantrum or an anger outburst. This is what I mean, like describing the symptom and the circumstances behind it. This is the DICE approach. It's a commonly used approach just for you to try to elicit the details of the behavior, when it has happened, where it has happened, and how it has happened, how it has affected others, what kind of distress or safety issues it could have happened, and then investigate patient factors. For example, was the patient tired, sleepless at that night, at that evening? Was the patient hungry? Is he having any kind of constipation or urinary retention that could be disturbing? Any kind of pain, any kind of infection that might be producing those or increasing the severity of the neuropsychiatric symptoms. And then the caregiver factors. One of the main factors for this is that when you have a depressed caregiver who is unable to give the attention and the effort the patient will be needing, including also environmental factors. Most importantly, what is the place around us? Where are we? How are we able to interpret around the environmental cues around us? And then create or collaborate about creating this treatment plan to address the specific factors that are trying. For example, sometimes patients might be agitated for no specific reasons, and they're unable to say why are they agitated. It could be as easy as having a headache or dental ache, but they're unable to express this. For example, if a patient with no clear reason for agitation, we might even just give a paracetamol and see if this has helped them in reducing their agitation, and then to evaluate what kind of modality you used for the treatment plan. Most commonly used are the atypical antipsychotics. It might be very complex for people who are not familiar with those medications. They carry a lot of side effects. It's difficult to maneuver around. They need to be monitored. The most commonly used are the third generation antipsychotics, and one of them is the brexpiprazole, which is the only FDA approved medication that has been approved for agitation in Alzheimer's almost a year ago. All other medications are non-FDA approved, but they are commonly used to treat different kinds of neuropsychiatric symptoms. I will be going through them briefly. Second generation psychotics, the best evidence goes for risperidone. There has been good number of randomized controlled trials, and then followed by olanzapine and quetiapine. Again, number 1, 2, 3 might change according to the study that or the trial that you're looking for. There's still no clear guidelines. This is the MOH protocol. At the big, they haven't changed it yet to include the brexpiprazole. All of those medications are used off-label, meaning that they're not FDA approved. However, the evidence has been supporting the use of those medications in the neuropsychiatric symptoms. Risperidone, olanzapine, quetiapine, all of them are second-generation medications, and they've been effective even in a personal experience of a psychiatrist, like being in that field for years. They have been effective in reducing the severity of a lot of those symptoms. So in last year, it was in May 2020, there was the first time a medication was FDA approved to treat a symptom of dementia that is a neuropsychiatric symptom, which is agitation. That medication, as I mentioned, is the brexpiprazole, under the name, brand name for Rexulti. It's a third generation antipsychotic. So it works mainly as a serotonin dopamine activity modulator. So it's a partial agonist for serotonin 1A and dopamine 2 receptors. At the same time, they're antagonists of the serotonin 2A and the noradrenaline alpha 1B and 2C. So if you understand, if you understand the pathophysiology behind it, you will be more understanding how this medication will work and what kind of effect it will exert and what kind of side effects it also exerts. One point I would like you to put in mind, as this medication is available now in Saudi Arabia, it is being more and more widely used. It's metabolized by the cytochrome P450, mainly 2D6 and 3A4 enzymes. Why is that important? Because there is a wide range of drug-drug interaction. So brexpiprazole was previously approved for treatment as mainly for schizophrenia and then for adjunctive therapy for antidepressants, meaning for severe or treatment-resistant antidepressant. We were adding those third generation medication to other choices of antidepressant to augment the effect to treat clinical major depression. So those are screenshots of the FDA website about Rexulti and or the brexpiprazole, and for how long it's been. It's not very long trials, but it has been tested for. And I mentioned it just to see that most of the patients in those trials were between the mini mental status examination was between 5 to 22. So we're having a wide range between early or let me say from the severe to the mild spectrum of dementia, and then they've used it on different types of agitation, and then with a wide range of age. So usually the starting dose would be 0.5, and usually patients would usually receive a dose up to 2. There are patients that have received a dose up to 3 milligrams, and it has been shown to be helpful. You'd usually see a significant or meaningful improvement throughout the week 12, or at least let me say throughout 3 months of using the medication and getting to the right dose. And that's why I tried to mention the Cohen-Mansfield Agitation Inventory, because it's one of the main ones that is used for to evaluate agitation and the neuropsychiatric symptoms. And it's easy to administer and follow up with it. So those are below are the risk that you need to be discussing when you're prescribing those medications, especially practicing who are in the primary care settings. Those medications will put you at a higher risk of falls. So you have to take any kind of risk for falls, especially for dementia related with movement disorders. Those medications have extrapyramidal side effects, which might be worsening agitation. For example, patients might have dystonia, which is painful. That could be make them agitated, or a common side effect of the third generation antipsychotic or the brexpiprazole or Rexulti is the akathisia, or the need the persistent need of moving around, which could be that you would think that this medication might not be working, or probably this is only a side effect of the medication. If you treat it, you can have other beneficial effects of the medication. Because of sedation, which might also increase the risk of falls. worsening of cognitive impairment, especially with medications where there is sedation, the medications that work on anticholinergic receptors and antihistamine receptors. They will worsen cognitive impairment, and it's directly related to the timing of the medication. Care providers will tell you, I gave the medication, and for a 1 or 2 hours post the dose, the patient has been really bad. He was just like mumbling with incomprehensible things, for example. You have to look for Q2C prolongation, as there is a risk of for sudden cardiac arrests, sudden death. There is the risk of metabolic abnormalities. It might worsen diabetes, might worsen hypertension, dyslipidemia, as well as there's weight gain and higher chances for stroke. So overall, it will increase all-cause mortality. So put in mind all those risk factors when you're prescribing those medications. Atypical antipsychotics, all of them, from the first generation to the third generation. The first generation or the typical are not commonly used except for haloperidol. The second and third generation are commonly used. All of them have the black box warning of causing a sudden cardiac arrest. Usually, this is discussed in the clinic with the care providers that there is this risk is present, although it's not as common. Most of the time, after discussing and trying to explain to the care provider the benefit of those medications, you will be able to proceed with the medication even with this black box warning, because there will be a really urgent need to use those medications. That's why it's a good idea when you are able to taper those medications off, you will be tapering them as soon as you can. And then at the same time, if you are using them, it will be a wise idea to look at the other medical things that you can do, pharmacological things, other medications, and environmental factors that could help optimize the effect of those medications. And then there will be the non-pharmacological intervention will
Dr. Now you have 5 minutes.
Oh my God. Okay, I'll try to go quickly. So unfortunately, the neuropsychiatric are persistent, and they will require long use of psychotropic medication. Quickly, I'll go through antidepressants. They were the most studied is the SSRI and mirtazapine, trazodone as well. You will find them in the MOH protocol if you are using them on those segment of patients. And what to look for, SSRIs look for sodium level. It's important. Worsening of suicidal thoughts or behaviors, and look for ECG changes, especially the Q2C prolongation. If you're using mirtazapine, look for bone marrow depression. It's all in the guidelines. That's why I'm telling you to use them. Trazodone is also important to look for the LFTs factor. Those things are cognitive enhancers. They do show improvement in the neuropsychiatric symptoms, or over the course of long use. I'm not sure if they are delaying the cognitive decline, or they have a direct effect on the neuropsychiatric symptoms. Memantine did not show so much effect on the neuropsychiatric symptoms. This is again going back to the MOH, what to look for or to monitor if you're using acetylcholinesterase inhibitors, pulse and weight. They might cause sometimes significant bradycardia. Mood stabilizers are usually used. Lithium or carbamazepine are one of the most beneficial. Not so much if they could be used as second agent after the antipsychotic medication. So targeting the choice of the drug according to the behavior. If you are dealing with delusions or hallucinations or psychotic medications, go for antipsychotic medications. If you're having anxiety and depression, use SSRIs. If you're having disinhibited behavior, irritability, you can go for both choices. And again, it will go to the clinical judgment of you as a doctor and the medical condition and other factors involving the choice of the medication. Benzodiazepines are usually a very good idea if you need a quick response in highly agitated dementia patients, but it will be a bad idea to use in the long term because of the problematic risks of excessive sedation and impaired cognition, increasing the risk of falls and fractures and delirium. Other agents that have been used also prazosin, which is used for to improve the sleep and PTSD patient. Melatonin, there is a role in improving the circadian rhythm disturbances that are usually expected in those patients. So just to ask yourself questions before choosing the medication. Is that behavioral sudden? Is it catastrophic? Can it be managed by behavioral, or do we need the medication as well? Is it explosive or a reaction to some kind of environmental factor? Is it a result of a delusion or a hallucination? Is it driven by depression or anxiety, or impaired memory and cognition underpinning this anxiety? Those questions will help you choose the medication. At the end, the psychosocial intervention remain to be the cornerstone of managing those symptoms better than the medications. Yet pharmacological treatments are preserved at severe cases with a high chance of patients who have high chances of harm or severe distress to the patient and the care providers, and they should be monitored and reassessed for its need regularly. There is a limited evidence of its efficacy, despite that it's being used very commonly, and we are in need of more randomized controlled trials to determine what kind of the effect of those medications we're having on those on our patients. And thank you so much. Sorry for taking a long time. I'm trying to race with time in this kind of talk.
Thank you so much, دكتورة لبنى. يعطيك ألف عافية.
So much to cover in time, so excuse me.
Yeah, I know. Inshallah, we'll have like this course was meant to be an introduction, so we're mentioning a bit of everything, but inshallah in the future we'll have more specific talks addressing everything in more details, as I see people are interested. A question to Dr. Lubna. So one of the audience is asking, usually for how long we should prescribe antipsychotics if needed, and how to monitor efficacy.
Well, that's the thing that's what I'm mentioning. According to you use it to what is the targeting symptom you're using. For example, if you're targeting hallucinations, it has improved. You will use them for at least a good number of 3 to 6 months. Sometimes we use them for years, and so it really differs from one patient to others. So there's no one size fits all. And when we come to those medications, there's a different range of symptoms. So what are the symptoms, how long it's presenting for, how disturbing it is, and how is it changing? Because symptoms will change throughout the course of the illness, as I was mentioning.
Yeah, especially in the very late stages of the disease when they're like bedbound, not doing much, and most of the behaviors that we were worried about, like wandering and some safety concerns, are no longer there. So
Yeah,
maybe it would be time to like wean them off the medication or
that's what I'm saying
decrease
about
the dose at least.
exactly monitoring and not just putting those medications, a patient on those medications and not following up. Monitoring is usually needed. For the big sum of time when we start with medications, we will use them for a long time if there's a good response to those. And you can monitor it through merely the Cohen-Mansfield that I've mentioned. It's very good inventory to keep a track on the symptoms that you are trying to target by those medications.
Okay, another question about duration of mood stabilizers.
So mood stabilizers, we can use them usually. It depends on what kind of symptoms if you're having manic symptoms, you would use them for as long as those manic symptoms, and then use them as a maintenance. Sometimes use mood stabilizer for agitation or anger outbursts. It might be of a shorter duration at this time. So again, there's no one size fits all. It's very variable, and I got a lot of calls from our primary clinic asking about those questions. Shall we continue the medication? What should we do if it's not working? So it's really a very you have to tailor it according to the patient and the care provider situation and how much of care and in supervision they need. A lot of the time, I'm saying this because you can deal with those symptoms in a behavioral manner that will be discussed later on by Dr. Mubili. And there's no need for those medications. But when you don't have so much of an environmental care around you, you will be needing those medications more often.
Yeah. So one more question for me is why couldn't we use amyloid targeting antibodies for moderate and severe dementia?
It's actually
So
what I mentioned, yeah. Sorry, there was no studies at all about it. Sorry to interrupt Dr. Roy, because I was just enthusiastic because I was just looking it up today. Sorry, go ahead.
yeah, so kind of, well, when we're giving amyloid targeting antibodies, first of all, we're assuming that amyloid is the cause of the disease. Now, we're not quite sure. We think that amyloid is a good biomarker. We're not sure if it's really causing the disease. But what we know, I would say not for sure, but what we know is that amyloid drives the position of tau. So usually amyloid is there, then tau comes, and then symptoms come. And we think that if we can stop amyloid from depositing, either prevent it in people who do not yet have amyloid, or remove it on those who already have amyloid but have very mild symptoms or no symptoms at all, we can prevent later on the deposition of tau and the development of the disease. Now, if we give amyloid to people who are already in the moderate to severe dementia, the damage is already there. We're not in the amyloid and tau discussion, we're already in neurodegeneration. So there's no way that you're going to revive the dead cells. And as we mentioned, these are diseases that are not 100% safe. So measuring the pros and cons and weighing cost and benefit, cost not only financially but like medically, it's not worth it. Now the other thing is no trial was done, or let me say all of the previous trials that were done on amyloid targeting antibodies, when they were done without selecting and separating those who have mild symptoms from those who have moderate and severe, the results were negative all of the time. And we did not start seeing positive results until we started specifically targeting those who are in the early stages of the disease. Now, there are a lot of controversies about amyloid targeting antibodies, and we're going to have a dedicated workshop for amyloid targeting antibodies and the selection criteria. But yeah, that's a very logical and important question. Um, طيب, I think maybe it's time for a break. Let's take a 5-minute break, and then we'll be back with Dr. Moody with non-pharmacological management of behavioral symptoms. طيب بسم الله الرحمن الرحيم. I think 5 minutes lapsed already. So it's my pleasure to present our next speaker, Dr. Moudi Tuwejri, who's a senior clinical neuropsychologist or a senior clinical psychologist at KFSHD. Dr. Moudi will be talking about an important part of managing the symptoms of Alzheimer's disease, which are the non-pharmacological approaches. So non-pharmacological management of Alzheimer's disease and dementia. Dr. Moudi, please, mic is yours.
Hello, everyone. Thank you, Dr. Ru'a, for your informative presentation and information about dementia as a whole and Alzheimer's specifically. And thank you, Dr. Ru'a and Dr. Lubna for the pharmacological management of Alzheimer's specifically and dementia as a whole. As you mentioned, they're quite tricky the conditions to treat. I think it would be similar to non-pharmacological management, but it's less confusing as we're not using medication. Before we start, I would like to share this video that gives us an idea about how people with Alzheimer's endure during a day. So this would give us it's nice to know because we talk about it and we don't know how they feel. So this is through the eyes of people with Alzheimer's, with someone with Alzheimer's or dementia. I'm just making sure that the speakers are working. Can everyone hear it? All right. What? I've forgotten. Should I? Just sit down. Just go sit down. Yeah. Right. Well, that way. I don't what? Oh, I don't know. Richard, my list. Should I go? Because I don't know correct. Oh dear. Oh, what? Chicken cheese. What? Chicken cheese? Sorry, oh. People with dementia have experiences like this every day. A little bit of understanding, tolerance, and patience can make all the difference. See what? If you go with the new seats just there, right? When we get there, I'll call you, okay? Okay, madam. I can't get on. Let me help you. This way. Thank you. Can I look at that list? Yes. Chicken and cheese. Oh. Let's go this way. Thank you. Find out how to become dementia friendly. Contact Alzheimer's Society.
Right, so we all want to be Alzheimer friendly, and I think it's very important for us as clinicians and people dealing with people with dementia to actually understand and share the awareness of that aspect of how they are frustrated most of the time. So I don't want to overlap and I don't want to repeat what has been already said about symptoms, but I have to point out that 97% of Alzheimer patients experience neuropsychiatric symptoms. And these symptoms are, as Dr. Lubna mentioned, anxiety, depression, aggression, apathy, agitation, and psychosis. And these symptoms, they give us these challenges that we live with, that people with people with Alzheimer's live with, and people looking after them and people living with them struggle with. And insufficient therapy that people receive that have dementia exacerbates their symptoms. So lack of efficacious therapies is an issue. Underdiagnosis is an issue. Socioeconomic burden is another issue. Increasing prevalence as well is an issue, especially when it's underdiagnosed. That makes it even worse. So we look forward to this lecture today, in addition to the other lectures presented by Dr. Ru'a and Dr. Lubna, is to share this with all these clinicians today to highlight the importance of correct diagnosis and the correct treatment plan that we set for our patients. Right. So for neuropsychiatric symptoms with Alzheimer's or dementia as a whole, from psychology point of view, we would like to do some screening. I know Dr. Ru'a will be discussing specific screening later, but these are just things to keep in mind that it would be good to address. So for anxiety, we have rating anxiety in dementia. That's a specific scale, different from the regular assessments that we use for anxiety. But for dementia patients, we use the rating anxiety in dementia. And it's quite applicable for people with dementia. Also, apathy. We have the apathy evaluation scale. Which is quite favored for people with dementia, as there are other scales for apathy. As well for depression, Hamilton Depression Rating Scale is advised for elder people, geriatrics with potential Alzheimer's or dementia as a whole. Similarly, there's another scale that is recommended for people with dementia to test for depression, which is Cornell Scale for Depression in Dementia. And that is specific to dementia. When it comes to agitation and aggression, we have the Cohen-Mansfield as well as Dr. Lubna mentioned already. So these are the scales or the psychometrics that we're using they're recommended to be used for people with dementia. And of course, Alzheimer's, as Dr. Ru'a explained, Alzheimer's is under the umbrella of dementia, in addition to other diseases as well. And when we come to the clinical assessment of Alzheimer's, we look at it from a psychology kind of point of view. Is more of we focus on the scores. So we look at the MMSE, which is the mini mental state exam, and we kind of focus on the score. So when we have 26 or plus out of 30, we consider that a mild cognitive impairment. But when it is more severe, it'll be entering. So if the score in front of me is 20 or less, then it will be, 20 or more than 20 will be mild Alzheimer's. And then if it's between 10 and 19, we'd consider it moderate. And then less than 9 is severe Alzheimer's. And also the average duration of the disease plays a role in this. So as you can see, 4 to 10 years will still be within the MCI, but this is a combination of all of the above. So if we have 4 to 10 years of duration, average duration of the disease, in addition to the psychological symptoms reported like apathy and anhedonia, then we are looking at MCI. If we are looking at a score above 20 with average duration of the disease 2 to 4 years, with behavioral psychological symptoms presenting apathy, depression, and some anxiety, then we're looking at mild. Then there's the moderate stage, which is the next level when we have MMSE score between 10 and 19, and then the average duration of disease stage would be 2 to 10 years. But in this category, we'll have more behavioral and psychological symptoms. So we'll have delusions, we could have insomnia, agitation, aggression, comprehension issues. And then the next stage would be the severe Alzheimer's stage from there, which could start affecting daily living activities and worsened insomnia. So depression effects on people living with Alzheimer's or dementia, it's devastating for both patients and caregivers. And we have to emphasize caregivers because they are the people living with the patient. And it significantly decreases quality of life. Greater impairment in activities, daily life, which worsened cognitive function, increased physical aggression, and cause earlier nursing home admission. Of course, in our culture, this is all Western studies, but in our culture, we do not result into nursing homes as quick as Westerners do. But as well, we would like to have less pressure on people in their houses because there is a social burden that comes with looking after someone with dementia. And as Alzheimer's advances, there is an increasing caregiver burden, as I mentioned, and higher prevalence of depression among caregivers. So what we can do is look at our prognosis, look at the quality of care for people with dementia, look at the early to predict the signs earlier and to see the symptoms before it starts to affect the caregiver. Nearly 80% of patients with Alzheimer's have family members as their caregivers, so the family is quite affected. And over half of Alzheimer patients need care for greater than 8 hours a day, which can be both exhausting and frustrating. Also, studies have shown that caregiver depression occurs in roughly 30% to 50% of cases, with some studies showing up to 83% of cases. Management of depression, Alzheimer's, or dementia. One of the main things we'd like to focus on and start to encourage our patients to do is physical exercise. As simple as it sounds, it is quite important. The second management we can start doing is cognitive behavioral therapy, or CBT. Also, cognitive stimulation therapy, CST. Exercise and CBT have been shown in some studies to reduce depressive symptoms more than twice that of standard medical therapy. And in medical therapy here, they're talking about pharmacology therapy. Improvements in mood in caregivers have been shown to produce positive effects on the neuropsychiatric symptoms of the patients that they care for them, of the patients. Also, cognitive stimulation therapy involves activities and exercises that encourage thinking, concentration, communication, and memory in the person with dementia. Also, CST involves talking about day-to-day interests, past events and memories, and information relating to the current time and place. Examples of CST are Simple games like word games, puzzles, music, and practical activities such as baking or gardening. Both cognitive stimulation and psychological therapies have been shown to reduce rates of depression in people with Alzheimer's. I'd like to talk, just to mention, this is a video talking about cognitive stimulation therapy, and it's quite simple yet so effective.
One of the main early interventions I've been involved with is cognitive stimulation therapy, which is a type of intervention often done in a group format where you're working with people with dementia who have mild to moderate Alzheimer's disease and other types of dementias. And this helps to stimulate their cognition and their quality of life. And it's now in around 20 countries across the world. The strength of the approach is that it's a psychosocial intervention that's enjoyable and very popular. And because it's very interactive and it has a game-like kind of format and a format to encourage discussion and interaction, and use a variety of things from things like reminiscence through to the arts, through to topical debates about various things, including issues to do with finances, how things are now compared to how they were. That people enjoy it a lot, and because it's pitched at a level that suits them, this can be very helpful in terms of helping to stimulate memory and improving communication. There's been quite a number of randomized controlled trials published. We've also shown that it's cost effective, so it's quite cheap to do. It's also quite easy to adapt it to different cultures. So we've had, for example, cognitive stimulation groups running in Japan, in Nigeria and Tanzania, as well as a number of other parts of the world. And it's kind of catching on. It's also useful because it's relatively cheap to do and can be done by people using the guidance and the manual and the DVD. It's got some advantages that it can be quite a lot cheaper than medication, say. And if you're looking at low and middle income countries, so the cost of medication for people with Alzheimer's disease can be very high relative to the overall budget available for their care. It's being used in about 80% of memory services in the UK now. So the implementation has actually been going very well. And it's interesting that quite a lot of other countries are starting to take it on, because the manual can be adapted for different languages and different cultures. So it's a good example of a psychological intervention which can be implemented in different countries on a wide scale. And I suppose it's recommended by Alzheimer's Disease International. And so that's one of the ways to help get things more widely implemented, is to have a prestigious international organization like this endorsing it because of the very good evidence base.
So this shows how simple it is, yet it's so effective, the CST. Second. So anxiety effects on people living with Alzheimer's. Again, it's frustrating for both patients and caregivers, and anxiety affects memory, attention, and cognitive abilities. Anxiety in Alzheimer's could worsen cognitive decline and lead to premature institutionalization, decrease quality of life, increase caregiver distress, and increase hospital visits with subsequent increased cost of care. Patients with Alzheimer's may experience a fear of the unknown future, as well as feeling insecure. This may cause patients to become hyper-alert and misinterpret normal stimuli as dangerous. And there has been a lot of studies that came out showing how people with Alzheimer's and people that have anxiety, only anxiety, and then people with Alzheimer's with anxiety, and how they were their perception toward sad faces or anxious situations or fear was very different, as people with anxiety and Alzheimer's had more intense effect. Also, anxiety is associated with an increased risk. developing dementia and cognitive
Marwa.
impairment. Is everything okay? Okay. There is a 57% higher risk of developing dementia in older adults if anxiety is present, and hence early detection of anxiety and management of anxiety at an early age could help us avoid dementia, I would say, in a way, or worsening mental health. The study also showed that the association was higher with increased age, suggesting that anxiety could be an early symptom of dementia. There is a correlation between anxiety and age. So the older the adult is, the more anxious they get, and that's understandable due to the usual biological effects of age and different and changes when it comes to health. Also, anxiety increases the overall rates of conversion from MCI to dementia. So when I have anxiety, in addition to mild cognitive impairment, I am leaning toward dementia. So the patient starts to enter the dementia stage. Management of anxiety and Alzheimer's or dementia is similar to depression. However, we can add to it reassurance and redirection, social support, group music interventions, maintaining a calm environment, and minimizing anxiety-evoking triggers. So a 2019 systematic review showed that cognitive stimulation therapy, music-based therapies and interventions, as well as CBT, were the only 3 non-pharmacological interventions for anxiety and depression and depressive psychiatric that improved cognition. So they helped a lot of patients with that. Hence, we are recommending it and we are highlighting it. Group music intervention reduce dementia-associated anxiety, which is quite interesting. It's actually a really nice study to read. It's quite interesting, and I think it could be applicable to our culture. Also, routine chores or other repetitive tasks to stay busy may help decrease the anxiety in a patient with Alzheimer's, as they do not have to make decisions or remember what they should be doing, hence less anxious. So also physical exercise has also been suggested to modulate amyloid turnover and overall reduce anxiety in Alzheimer's, as Dr. Rao was talking about amyloids. They're quite essential in Alzheimer's. These are some examples of the daily visual schedule that we can suggest for our patients, their caregivers, families. These are things that we can start doing for them to establish a routine for them, because routine is good. Routine is very good for people with dementia or memory issues in general. It's good to have them in a board and cut it out in a board or have it in a notebook or somewhere where they can see every day. People with Alzheimer's, they love routine, so they like to stick to a schedule. So they like to eat the same time, lunches is the same time, their coffee time is the same time. They like similar foods, they don't like to change, they don't like new things, and that's normal with age and with Alzheimer's or memory issues or dementia as a whole. Repetitive task for people living with dementia is quite good for them on so many levels, because it kind of like what we're doing here, we're kind of working on their implicit memory. So we're allowing them to repeat tasks over and over again. Things that sound fun for some people, like knitting, crocheting, folding laundry, organizing papers, sorting cards, rolling a ball of yarn, tying knots in a rope, organizing items by color, shape, or design, stringing paper clips, sorting buttons by color, size, and shape. Whatever task you choose, remember to be mindful of your loved one's cognitive limitation. So we don't want to stress them out as well. So depending on what they like. So if we have an older lady that she's always been knitting and she's always been sewing and she likes knitting and sewing, it would be applicable to suggest for her to start knitting again or crocheting or because all we want them to do is do a repetitive task that could be as simple as possible, yet they are still doing it over and over again. So all we want to do is do a repetitive task for them that they don't have to get anxious about forgetting, because when they do something over and over again, it becomes routine, and that's good for them. And as Dr. Lubna mentioned, psychosis is another symptom that people with Alzheimer's and dementia tend to struggle with, but not as often as as anxiety and depression, but it's still there. So psychosis refers to a set of symptoms consisting of delusions, hallucinations, and disorganized thought and speech. Psychosis in Alzheimer's patients is one of the most clinically relevant neuropsychiatric symptoms and may be one of the most difficult to control. Psychosis in Alzheimer's is associated with the concurrence of other behavioral disturbances, and the utmost bothersome are agitation and aggression, and that usually affects as well the family of that patient. Psychosis in Alzheimer's is correlated with accelerated cognitive decline, increased mortality, increased rates of institutionalization, increased cognitive impairment, as well as higher distress for family and caregivers. So psychosis could be quite challenging when it comes to dementia, and to manage that without medication is quite hard. So medication is essential in this aspect, and it is needed in addition to other things we can do with them. So many things in your environment can trigger psychosis symptoms. We never know what could trigger that psychosis symptom. Those things could include, and this is specific in dementia, shadows on the wall that looks like monsters, changes in the routine, too much or too little activity. And to help manage those triggers, you can remove or cover mirrors, clear floors, install bright lights to prevent shadows, try to stick to the same schedule every day, plan activities throughout the day that you or your loved ones enjoy. I want to talk about I want to show this video about mirrors, because I was not aware that mirrors could be that scary for some patients with dementia. And then I would like to mention another story about another patient. Okay. Sorry.
Today's tip is going to be about dementia and mirrors. Hi, it's me, Linda Burhans, the gal who cares for the caregivers with love, laughter, and lessons learned. Today we're going to talk about dementia and mirrors. One woman came to the support group and started telling me, I think my dad is intentionally peeing his pants, and not because he doesn't want to go into the bathroom. I don't understand why he doesn't want to go into the bathroom. When we go to my sister's house, he goes into the bathroom and there's not a problem. Well, I finally realized that as I sat down and really talked to him very calmly and seriously when he didn't have to go to the bathroom, is he told me is every time he goes in the bathroom, that old man is watching him. Because right behind their toilet, they have a mirror on the wall. He doesn't recognize himself as the old man he is today. He still thinks he's a young guy. And it appalls him that that man is looking at me when I'm trying to go to the bathroom. So we took care of that really easy. We just covered up the mirror. But mirrors can also be helpful with someone with dementia. There was another woman that said she would go into the bathroom and her mother would be there talking to herself in the mirror, not realizing it was herself. She told her daughter, she's a nice lady. I talk to her every day. That's kind of a good companion. So sometimes it can be a good thing too. But more often it's a frightful thing. I had a caregiver come to a support group one time and tell me that her husband took a golf club and broke the mirrors on the wall in their living room. They had a whole wall of mirrors because people were watching him. So I never thought about any of this stuff until I got involved with people with dementia. So mirrors can be very harmful. You may have to cover up a bit. Be better for your loved one, it'll be better for you. So tune in next week for another.
Right. So it's quite interesting. I remember I had a patient, she had Parkinson's with dementia, and I remember her saying she does not like going to one of her daughter's houses. And I thought it was about the daughter, and then I figured it out because she has a lot of mirrors in that house. Later on, I figured that out. And when I was researching for this presentation, I thought, yeah, mirrors could be quite scary for some people with dementia, especially the later stages. Right, so brain exercise for people with Alzheimer's. So the main thing we want to do with these brain exercises is to keep the brain active and challenged. That's our main goal. So we can do so many things depending on the patient, depending on their cognitive abilities, on their educational level, and always to keep in mind, you don't want to stress them out. This is not to stress them out. This is to actively engage, get them engaged and get them moving and going and thinking and doing something. So testing the recall. So test the recall is a good way to do things, to just keep the brain active and sharp. Also, let the music play. So music, if they used to play an instrument or they like to sing, they can start singing along with the old songs, just to keep that going and that memory aspect going. Do math in their heads. The other 3 weeks ago, I had a patient in the clinic who was a math teacher, and now he's retired, and he has Alzheimer's now, diagnosed Alzheimer's, early stages, and he was a math teacher. So I thought he would enjoy doing Sudoku. So I introduced him to Sudoku. So now he does Sudoku every day, and that is quite good for him. And he's been doing this now for 6 weeks. And last time I checked in with his son, he said his dad does not miss his keys as often as he did before because he used to put the keys in different places. So it must have done something. It must have activated something in his brain. Also, taking a cooking class. So cook something new, something different, learn something new. It depends on the person. So these can be different for different people. Learn a foreign language, something you've always wanted to learn, something different, or learn a language that they used to speak, but they don't speak it anymore. Also create word pictures. So creating word pictures is about visualizing. So you visualize the spelling of a word in your head, and then you try to think of the other words that begin or end with the same 2 letters, and that keeps the brain going. And this could be applicable or suitable for someone that is a reader, someone like retired teachers, retired physicians, retired people that used to read, that they would enjoy that kind of activity. Also, draw a map from your memory. So, for example, after coming home, you can ask them to do like draw a map of the area in your head, so they can tell you where is that. So for example, if they came back from a mall, they'd tell you where was the entrance, and was it north, was it south, and how did they get around it, and where was the parking lot, where did they park the car, and where did they go in from which door, and how many doors are there. So to keep that kind of navigation aspect in their brain active. Also, we can challenge their taste buds. So when eating, we can try to figure out the ingredients that were used in that meal, or what kind of herbs or what kind of spices they added. And especially family members, they can try that a lot with them. So they can add a little bit of lemon and see, oh, did you notice it's a bit tangy, or is it a bit sour? So that kind of thing, just to keep them on their toes, to keep their brain sharp. Also, refine your hand-eye coordination. So that kind of refinement would be similar to motor skills. So something like knitting, crocheting, something that they use their eyes and their hands with. When it comes to, that would be more applicable to females, but when it comes to males, it could be something like fixing anything with their hands. They can screw on a nail or fix anything. They can do anything with their hands, and they can see it. It's like basically we're working on motor skills here. Also, if the person is still active and the person is still healthy, learning a new sport that's not very scary or dangerous could be applicable. And the new generation of people in their 60s and 70s are quite different from the generation we used to see 10 years ago or 20 years ago. They're quite updated, more modern now in Saudi. So I think they would be up for different stuff like this, and they would be interested, and their children and their families would be interested in getting them involved in such things. These are general activities that are fun to do with someone with dementia, for people, for families. So we kind of divided them here in different aspects. So there's arts and crafts, so painting, knitting, memory scrapbook. Light physical activities like Tai Chi, gardening, water aerobics is really good for people with dementia, and generally all geriatrics is good for them because it helps with their joints and does not pressure them. Tabletop games, Scrabble, bingo, dominoes, also music and reminiscence. So when we play music for people with dementia, we're not really just playing the music, we're playing the memory. We're replaying the memory that they associated that music with. So we're bringing back all the old memories and asking them, just like when we're looking at an old family album and ask them, who is this, and when was this, and where was this, and what was this about? And it seems like there was a party, or there was like a birthday, or something is going on in that album, and they will share that information with you. And what we're doing here, really, we're kind of keeping that brain active for people with dementia. Keeping that active helps delay more symptoms. Right. So how does our brain how does brain activity in general or exercise help our brain be better? So studies of animals show that keeping the mind active may reduce the amount of brain cell damage that happens with Alzheimer's, specifically with Alzheimer's. Also, support the growth of new nerve cells. Also, it can prompt nerve cells to send messages to each other. Also, keeping the brain active with exercises or other tasks may help build up a reserve supply of brain cells and links between them. You might even grow new brain cells. Technically, it could be new brain cells. I'm not sure if it's new brain cells, but it could be something similar to new pathways for the neurons to connect. This may be one reason scientists have seen a link between Alzheimer's and lower levels of education. Experts think the extra mental activity from education may protect the brain by strengthening connections between its cells. Neither education nor brain exercises are a sure way to prevent Alzheimer's. And I made that in bold because we're not preventing, but they may help delay symptoms and keep the mind working. Okay, thank you. And keep the mind working better for longer. I'm almost done anyway. Probably I'll just skip this one. It was just a video about a woman with dementia and her daughter looking after her. And I actually want to talk more about social burden, but maybe that'll be in another lecture. We can talk more about it because it does affect families, and it affects it tragically and drastically. These are the 3 golden rules for patients with dementia. So the first thing is, don't ask questions. Don't ask them specific questions. Ask them questions that you know they would answer. So do not put them on the spot, and do not embarrass them, because they are still aware, and they are still aware of and being embarrassed and being not knowing how to answer your question. So they are still there in that aspect. Also, listen to the expert. And the expert here is the person with dementia. So if they tell you, if you ask them, oh, where was this picture taken? They say, oh, it's in Korea, and you know they've never been to Korea. Do not say, no, you haven't been there. No, that's not true. Do not do that. Just say, oh, interesting. Okay. When did you go? So the third and final golden rule is do not contradict them. So if the person with dementia says, it's Ramadan now, just say, oh, is it? Okay, interesting. I didn't know. Do not contradict them. Do not correct them, because correcting them could confuse them. Because at this moment, their cognitive abilities are not the brightest, and contradicting them could confuse them drastically. And these are the three golden rules. I don't know why I have 1, 1, 1. I don't know why it should be 1, 2, 3. Yeah, and that is something I would like us all to share with the caregivers of people with dementia, even clinicians that work with people with dementia. Yeah, and thank you.
Thank you so much, Dr. Modi. This was very important, actually, in managing behavioral symptoms non-pharmacologically is very essential and a lot of times overlooked. So someone is asking whether playing puzzles and asking them about different things in their lives would be helpful.
Yes, so it depends on the person. So if I'm talking about someone that used to be a teacher and retired teacher, they would probably enjoy word puzzles. If I'm dealing with someone that does not have a high educational background, then that would be stressful for them. Then I would switch to something they used to enjoy. So if it was an old lady that used to sew, then we stick to sewing and those kind of activities that she's used to. Same thing if it's a male. What's his background? You don't want to stress them out, because you may cause more stress than helping them. So we look at the person and kind of like assess the situation. If the person is more literal, like a teacher, a professor, someone more associated with numbers, like a math teacher, an engineer, someone that dealt a lot with numbers, like an accountant, then we go to numbers, because they find it's a comfort for them. They're comfortable there. The main thing is we do not want them to be uncomfortable. We want them to be comfortable, but we want to keep their brain active as well. So,
Yeah.
so that's the main thing. So if depends on the person, that's the answer, short answer.
Yeah, I remember during my training in Baycrest, the social worker, together with the clinical psychologist in the behavioral unit and the occupational therapist, would sit and make a personal story of the patient. They would sit with their family and caregivers and listen about where he was born, where how he was raised, what his job was, his hobbies, and they would try to create an environment that's similar to the environment that he was living in. So if he likes a specific type of music, they would play that music. If he has a
Yeah.
certain hobby, as you mentioned, they would try to if it's doable in the floor, they would try to provide
Yeah.
that. So it's very important, going
Because
back to the background of the
yeah,
patient, as you mentioned.
it's all about making the patient comfortable. We're focusing on comfort. We're focusing on familiarity. So we want them to be familiar. We want them to be comfortable. At the same time, we want to keep the brain active. So, but we don't do it in an annoying way. We try to make it in a
Yeah.
fun way, so they are engaged. So that is definitely something to yeah. They do these social stories, they call them, where they actually write the story about the person, the actual patient, and then they tell the patient the story as if it's someone else. And what happens is the patients will remember things, and they're like, oh yeah, I went to engineering school. Oh, I worked in that company. I did this. And it would be interesting to have the patient getting engaged and interested. That's a way to get them involved with you. So that's quite a good way to get them interested and basically
Amazing.
communicate, yeah, and talk, because they start to stop talking. They don't talk.
Yeah. Well, thank you so much, Dr. Modi. That was
Thank you.
very insightful. It was a great talk. Thank you so much.
Thank you.
I think if the audience don't mind, we can skip the break so we can conclude earlier because sleep is important for dementia prevention. So I don't want to keep you up late. So maybe Dr. Saad or Ms. Saad, we can proceed if you're around. Okay. So now we will proceed to the workshop. We will be talking about the basic cognitive and functional assessment tools. I'll be presenting this with Ms. Suad, who's a senior clinical psychologist in King Fahd Specialist Hospital, Dammam, where we all work together. And we will try to go over some basic and commonly used cognitive and functional assessment tools. Okay, so I'll first go over some tips in history taking, what questions to ask. So when you take history of someone coming to your clinic complaining of forgetfulness, first of all, you need to ask about the chief complaint. So you want to know what is it exactly that they're here for. Sometimes, most of the times, they would say we have memory issues, but if you ask more, it may not be really a memory issue. It might be a visuospatial dysfunction. So they may mean that we forget places or we forget how to go to places, but not really we forget events. Or it might be simply a language problem that they lost the meaning of words or they forgot the meaning of things. So it might be a language problem. So you need to ask what is it that they're here for, and then you need to dissect that more. You need to ask about the age of onset because, as we said, like for every age group, there are some common dementias that come with. What's their first language? Because it makes a lot of difference in the cognitive assessment tools that you're going to use. Most of our patients are their first language is Arabic. So by the way, just because your patient speaks English does not mean that you can use the English form of the so what I mean is, for example, you and me, we both speak English as our second language. You cannot assess my cognitive function using English if I have a cognitive problems. You should use my native language, my first language, because second language, for so many reasons that we can talk about later in languages workshop, but that's very important. Years of education, you need to put things in the context because definitely someone who received 6 years of education would perform differently than someone who received 12 years of education. Their norms, their expectations are different. Occupation, because as was mentioned several times before, so the background of the person makes a lot of difference in the way they react to your assessment and the way you interpret the findings. Premorbid intellectual abilities. So sometimes I see a lot of people, for example, while I'm doing the assessment, they would say, if there is a drawing, for example, they would say, well, he's been always bad with drawing. It's been always his weak ability. So putting things in the context. So it's very important to know what are, sometimes people come with cognitive decline and they have ADHD in their baseline, for example. Sometimes they come with cognitive decline, but they tell you, well, I've been always bad with parking and driving. And so you need to put that in the context. Handedness, so right or left, we neurologists love handedness. And of course, tempo. Like, how did this progress? Was it gradually? Was it sudden? Was it very quick? So how did this evolve over time? Then we will go through some more questions. So you need to ask about, so as we said, mode of onset, memory. So in the cognitive domain of memory, you ask about whether the person forgets names, misplaces objects, repeats questions and conversations, uses compensatory strategies. So someone who has been always sharp, has been always able to remember everything, suddenly is using notes and suddenly is using alarms. Now, if this has been always the case, this is a person who has been always using compensatory strategies, you don't consider this a problem. But if it's a change, it's something new to compensate for the forgetfulness, then that's a red flag, like something to mark. Mixing up dates, forgetting appointments, leaving the stove or the tap on. Executive dysfunction, like difficulty planning and organizing, someone who is always able to plan big events in the family, trips on summer vacation, who's unable to do that anymore. Multitasking, so a mother who is able to do several things in the same time, like taking care of children and cooking and doing several things in the same time, who's unable to do that anymore. Poor judgment, bad decision, difficulty with problem solving, impulsivity, repetitive and stereotyped behavior, or perseverance, and restlessness that could signal executive dysfunction. Attention, so losing track of thoughts, someone would in a conversation and suddenly they're talking about something else, so they lose track of thoughts, or you're talking to them and they're suddenly wandering in their thoughts, and they're just asking you, what were you talking about, or what is it that we were talking about? So someone who's easily distracted, unable to follow a TV program anymore. And of course, language problems like word finding difficulties, speech problems, comprehensive deficits, pronunciation problems, loss of word meaning, which is common in some primary progressive aphasias. So someone would be sitting across the table and you ask them to pass you the plate of pasta, and they're like, what's pasta? They no longer know what you're talking about. Slurred speech, or speech that do not make sense. Visuospatial, as we mentioned before, getting lost in unfamiliar places or in familiar places. So in the beginning, usually unfamiliar, and then later on in familiar places. And personality behavior that could be signaling towards behavioral variant FTD, like disinhibition, change in social and interpersonal conduct, apathy or inertia, changes in emotional expression, reactivity, empathy, sympathy. They don't care anymore if someone passes away in the family or if there is a wedding in the family. It just does not concern them. And it's not because they're apathetic, it's just because they have no emotional reaction to that anymore. Change in eating habits, especially overeating, binge eating, or eating ineatable objects. I remember I had a patient who was by mistake, again, not because they are mixing up things, it's just because he lost the ability to distinguish between what's edible and inedible. He would, for example, drink ketchup, or he would put the sunblock in his coffee, thinking like acting as if it's milk or cream. So these kind of extreme changes in eating habits. And stereotyped compulsive ritualistic behavior. Of course, sleep disturbances, psychiatric symptoms that we've been talking about since earlier today. So again, it's very important to go over them. Okay, so next. So you need to ask about past medical history, past surgical, what medications they are on, because as we said, you need to clean up their medications. Sometimes some people would be taking antihistamines or whatever medications that they don't really need and can really impact their cognition. And family history, of course. So when you use screening cognitive assessment tools, you need to have a brief, quick testing that you can do in the clinic. I understand that you have a busy clinic and you cannot really spend 2 hours doing cognitive assessment. So you need something that is brief and covering most of the cognitive domains. Now, one thing that I need to clarify here and to emphasize here is that we don't really have a lot of cognitive assessment tools in Arabic. We do have an Arabic MMSC that was part of the Sirad that was translated, and normative values were developed in Oman. And we do have the Arabic MOCA that's available in the MOCA website. But I just want to remind you that we don't have validation for those. So the availability of an Arabic version does not mean that you can use it, and you can use the same cutoffs for our Arabic speaking and for our people who are coming from a completely different culture. So for example, the cutoff of 26 in Mocha, and we usually say below that, this person has mild cognitive impairment. You cannot use the same cutoff for our patient. And I think the best way to use these cognitive assessment tools is to use them to compare the patients to themselves, but not to decide whether this person has dementia or whether this person has severe cognitive impairment or mild cognitive or moderate cognitive impairment. You cannot really make this conclusion based on the available data that we have today. Another thing is, other than comparing patients to themselves. Okay, I lost my track of thought, so I forgot the other point that I wanted to say, but I'll come to it later. So you need to understand that during cognitive assessment, the assessment is hierarchical. So what I wanted to say is you may have a person who can score, for example, 10 out of 30 on MMSE, but the reason is they have Broca's aphasia. So they don't have dementia. So the score itself on MMSE or MoCA does not mean anything if you don't put it in the right context. The other thing is the hierarchy of the cognitive domains. We need attention to assess every single cognitive domain. So you cannot really go to someone in the ward who has delirium because of UTI and do MMSE, they score 3, and you say, well, they have severe cognitive impairment. You cannot do this because you need to have their attention, which is quite impaired in that situation. So you need to make sure that some cognitive domains are intact in order to put the other findings that you have in the right context. As I mentioned, they are very good for follow-up over time. The screening cognitive assessments, we don't have validation, as I mentioned. We only have some normatives that are not very detailed. And the difference between normatives and validated is that we think we know what's normal for our population based on the study that was done in Riyadh by Dr. Taim for Omoka, and that was done in Oman by Dr. Ammar for MMSE. But we don't have validation. We don't know what is the cutoff beyond which we say this is dementia, this is mild, this is moderate. We don't have that. Ceiling effect. So you may have people, as we mentioned, you may have 10 out of 30 and they don't have dementia, and you may have 30 out of 30 and they have dementia. If you have someone who has a very high level of premorbid intellectual level, someone who was a university professor, they may still score 30 out of 30 on MMSE or MoCA, but they might be impaired in their activities of daily living. So this is something that you need to put in mind. Okay, so next. Okay, so now I hand over to Ms. Saad to go over the basic cognitive assessment tools.
Thank you, Dr. Roa, and for all the speakers. So is sound clear?
Yes.
Okay. So as Dr. Roa mentioned that we have a certain instrument, we can utilize it to screen the patient cognitive assessment. Again, we would like to emphasize those instruments are just screening tools. So they can give you an indication, but you can't diagnose the patient accordingly. So the first one, it's called the mini cognitive, which is the short assessment. It takes like 3 minutes only, and we'll show it to you later in details. And the second one is the mini mental status examination. And the last one is the material cognitive assessment, and there is 2 versions, MoCA A and B. So again, those cognitive screening will help you to assess the patient cognitive dysfunction. And when you use those assessments, you have to use it with adult or older patient. And those assessments are a key, which means that they are an indication. It's required from you to go for further assessment. and it focus on the memory and attention and orientation. Actually, there are three. So the MoCA has a lot of cognitive domain. It helps you to track the patient cognitive function. One more thing, which is when you use those assessments, you can watch the patient progress over the time. Again, those assessments are screening tool, so you can expand your assessment by using additional assessment. Example, if you found out that the patient overall score and overall performance indicate that there is a struggle with their memory, so you have to go like specific assessment or battery for the memory. Again, as Dr. Roa just mentioned, that those instruments, it has lack validity in our Arabic population. So what we are doing, we are using the international score, the cutoff point. So the first one is the mini cognitive. As I mentioned earlier, it's administered within 3 minutes only, and it screens the memory, language comprehension, and visual motor skills and executive function. So this is actually the worksheet. At the beginning, you have to take the history. You will address the patient data in terms of the name, age, and so. And before administering the test, you have to make sure that the patient, within their best condition, they slept well, they eat well. If they need to wear glasses, so their glasses is with them. So they are in the best condition. So sometimes you will receive a referral for cognitive assessment, but maybe the environment inconvenient for the patient. So you have to work with the patient interest. So when we do the mini cognitive assessment, you will start the assessment by telling the patient that I'm going to do an assessment to you or screening to you. So I will be saying a list of words and I would like you to repeat them after me. So here there is almost like 6 versions of words. You can use any one of them, and you have to repeat them 3 times. In each time, the patient should repeat it after you. After this task, you will ask the patient, and you have like to walk with them step by step. You will ask them to draw the clock. So at the beginning, they have to draw the contour, and then you will ask them to place the number. And then when they completed the number, you will ask them to set the hand on 10 past 11. And after this task, you will ask them to recall the given word. So the calculation or the scoring for this screening, you will one score for each task, and then as you see here, if the patient got 3 on the minimum, the cut point, that's indicated clinically meaning cognitive impairment, and if the patient got 4 or 5, that's mean the patient functioning within average. And here an example for the Arabic version. You can see here 3 draw for the clock. So the first one you can see number are missing, number 1 and 2. And for the second draw, you can see the hand, the patient didn't set it as requested. And for the last one, the watch looks like appropriate. The hand is there, the number, the contour, and everything in place. So for this, the patient can get 1 score. For the mini mental status examination, it's created in 1975. And this instrument, it takes like 5 to 10 minutes to be administered. And it is actually widely used with elderly patients. And here you can see the cutoff point, and Dr. Modi mentioned earlier exactly which score indicated that the patient functioning within the average, and when the patient has the mild cognitive impairment, when they score 19 to 23, and for the moderate cognitive impairment 10 to 18. less than 9 and less, it's indicated severe cognitive impairment. So again and again, you have to be careful. Using this instrument, it didn't tell you the patient, it is not a diagnostic tool, so you can't tell the patient having dementia or Alzheimer. It's an indication, and you have to watch the patient through that time. So if the patient got like 30 point or got the lowest, which is 9, this is never mean the patient having the diagnosis. And you have also to watch the patient performance. As Dr. Aroa mentioned earlier, there is an anxiety, there is mood change, there is personality change. All of those things you have to take it in mind. There is no score for those aspects, but you have to mind it and write it in your observation notes. So here is the mini mental status examination. So at the beginning, you will ask the patient to tell you what is the date of the year and what is the season. When we say the date, we mean the date and the day and the month. And then, which is related to the patient orientation. And then you will ask them to tell you where they are and in which region, and the country, the city, the hospital name, and their location in terms of which floor or clinic. So after that, the examiner will ask the patient to repeat 3 things after him or her. And you have to make sure that the patient repeated those 3 items after you correctly. And then you will move to the second task, which is you will tell the patient, I would like you to count backward from 10 by 7. So they will start by the 10 and then 93, 86, and you have to watch them and write their responses. If the patient could not make this task, there is an alternative task, which is the patient will spell a word to you, but in the backward conditions. So they will start with the D and then they will end with the W. And then you will tell them that earlier that I told you 3 names, and they would like you to say those names. And you will write the patient responses. And then just simply show the patient a pen or any object like a pencil or your hand watch and ask them to name it. And then ask the patient to repeat a phrase after you. No, it's, and, or, but. And you have to really be careful to watch the patient responses. They may make a mistake. So if they make even a small mistake, it take in consideration. And then you will hand the patient a paper and tell him, I'm going to give you a task and I would like you to listen to the instruction and follow them. And then ask the patient, take the paper in your right hand, fold it in half and put it on the floor. So watch the patient and see how they are performing this task. And then give them a paper, and in this paper you will write an instruction and tell him, now I will show you an instruction and I would like you to read it and follow the written instruction. So what's written in this paper, it's close your eyes. And then you will ask them to make up any sentence, but you have to make sure this sentence contain a noun and verb. Last things, as you see this shape, you will ask the patient to copy this shape accurately as much as they can. And you have to, when you score it, you have to make sure the angles are drawn accurately, and the two must interest. And when you score the MMC, you have also to take in consideration the patient education. And again, a reminder, the MMC, it's an indication. It doesn't give you a diagnosis. For the MOCA, it was created in 1996. And as I mentioned earlier, it has 2 versions. And it was validated for the patient with a mild cognitive impairment. And the overall score is 30, and it takes 10 minutes to be administered. What's good about the MOCA, the sensitivity and specificity for the patient with MCI, 90% and respectively 87. One good point about the MOCA, it screens the following domain: the visual spatial ability, which is really matter for patients with dementia and Alzheimer, and the executive function, attention, concentration, and working memory, language orientation for the time and place. So if the patient education level is 5 years and more, you will use MOCA A. And if their education level is less than 5 years, you can, sorry, if the patient education level is 5 years and more, you will add 1 point. And if their education level less than 12 years, you will add again 1 point. But if their education more than 12 years, you don't have to add this point. Why I'm saying the 5 years and 12 years? Because MOCA A, it has to be administered for those patients with this education level. And for MOCA B, it's used for illiterate patients and for those population with education level less than 5 years old. And the cut point is 26 or more. So if the patient scored 26, that's considered they are functioning within average. And if they got less than this score, that's mean there is an indication with their cognitive ability. So you have to, it looks like an easy task to be administered, but you have to, again, I would like to emphasize that you have to choose the best environment to administer this test, and you have to say the instruction carefully to make sure that the patient able to understand you. So for the first part, which is assessing the executive function, the first one is called the trial making test. So you will ask the patient and you will point for at number 1, which is the beginning. I will ask, I would like, again, you will tell the patient that I'm going to do a screening test to you, and I would like you to listen to me carefully and follow the instruction. So you will start by the trial making test and saying, so please draw a line going from A, from a number to a letter in ascending order, and you will point for in the beginning, number 1, okay? And then you will show them where they end with the letter E. And you have to watch them when they perform this task. Sometimes some of the patients, they will look like anxious, so you have to keep in mind this. Some of them, they will make mistake and they can correct themselves, so that's considered as a correct responses. And then you will ask them to copy the cube. Again, you will ask them, so please copy this draw accurately as you can. And then you will ask them to do the draw, the clock draw, and you have to focus that the patient draw the clock according to the 3 elements, the contour, place. Some of the patients, they will draw it in a square shape or in a circle. It's okay, it's acceptable. You have to make sure that the contour is placed and the number placed in order and the hand. So you will tell them, please draw a clock and put all the number and set the time as it's written here, 10 past 11. And then you will go for the naming task. You will ask them to name those animals. And for each animals, the patient will respond to it correctly. They will get a score. And then you will move to the memory task. You will tell them that I'm going to say a list of words, and they would like you to repeat them after me. And you have to say this word in a rate 1 per second. As example, you will say face, velvet, and so. And then once you finish, you will repeat those words again, and you will ask the patient to repeat them after you. And then you will move to the attention task, which is the forward digit span and the backward. You will tell the patient that now I'm going to say some numbers, and they want you to repeat them after me. And the patient will repeat them. Again, you have to be careful that when you say the number, you have to use again the rate of 1 digit per second. For the back digit, you will say the same instruction, but you will ask the patient to repeat them in the backward order. And then you will ask the patient to move to the other task, which is the patient must knock their hand on the table or make any sound according to their ability when they listen to letter A. So what you are going to tell the patient, I'm going to read a sequences of letter. Every time I say the letter A, tap in your hand once, and you can make a trial to make sure that the sound is clear so you are able to deduct the patient performance. And then you will start saying those letters. And then you will move to the calculation task. You will ask the patient to make a calculation, and you will tell them, now I will ask you to count by subtracting 7 from 100 or 60. Actually, there is a different type of mocha. So here you can see mocha start by 10. In other version, they start by 60. So you have to not just memorize those tasks by heart. You have to look carefully. Yeah. Sorry. So you have really to watch your steps, and you will ask the patient to make the calculation. If they ask you, example, if the patient say 93, and then afterward they ask you, what did they say? Or what did you ask me to do? So if you did not say the instruction, if you did not, if it wasn't clear, you can repeat it. And for the calculation, you see the calculation. The scoring is clear in the worksheet. So if the patient got 4 or 5 correct subtraction, they will get the maximum score which is 3. But if they got 2 or 3 correct responses, they will get the score 2. So, and if they got 1 correct response, they will get the score 1. For the language task, you will ask the patient to repeat a sentence after you. Again, you have to watch the patient response. They might miss word or maybe change something. So if they made a small mistake, it's considered as a wrong responses. And for the fluency task, which is related to the language, you will tell the patient that I'm going to give you a letter, and they would like you to say a word as much as you can within 1 minute. And you have to tell the patient that to not use a proper noun or number or different form of the given word. So if the patient give you 11 words, will score 1, but if they give you less than that, they will score 0. And for the abstraction, you will ask the patient to make an abstraction, and you will give them an example. So you will tell him that I will give you a 2 word, and I would like you to tell me to what category they belong. And give him the example, orange and banana. Some of the patient, they can't respond accurately. They will tell you fruit, but some of them, maybe they will tell you we can eat them, or we can make a juice of them. So you can correct them, and then you will go for the following task. So if you make 1 prompt, it's enough. You are not allowed to make another prompt. After this task, you will ask the patient to recall the given word, the 5 word. If they respond immediately, you will give them the score. But if they did not, you will walk with them through the journey. You will ask them, you will like to give them a help to remember it. So at the beginning, you will start with the category cue as example, part of the body if they couldn't recall the faces. So they may able to recall it. If they did not, you will give them a multiple choice. Is it a face or a head or leg? Some of the clinicians, they will miss this part and it's really matter. This is will help you. If you use the semantic, which is the category cue, that's help the patient is able to, the patient is struggling with the recall. But even if you give them the multiple choice and they weren't able to recall it, that means they are struggling with the coding. They weren't able to code the word. Last task, which is the orientation, you will ask them to give you the date. If they didn't give you the details, you will ask them one by one, the date of the day, the month and the year, and the day name. And of course, you will ask them to tell you the place and the city. And then you will score their performance. So again, just a reminder, if the patient got 26, that's considered within average. But for those patients with, but if they score less than that, that's considered, they may struggling with their cognitive function. This is, again, it's an indication. And don't forget to add 1 point if their education level is less than 12 years. So this is MOOCA B. It's similar to MOOCA A. But for the trial making, you will ask, the trial is different. So you can see here a digit and a square with a dot. So you will ask them to connect each number with the square with the digit. But in the MOOCA A, you will ask them to perform it within ascending order. And here you will tell them with increasing order. And for the memory, the word is a little bit different. It looks like easy. And for the verbal fluency, you will use the semantic. So you will ask them to give you a list of fruit, sorry. And the score is clear here. So you can score it according to their responses. And for the calculation is a little bit different. So you will ask them to provide 3 ways to pay using $1 coin, $5, until $10 bills for an object that costs exactly $13. And you will record their response, and accordingly you will score it. Again, then you will ask them to recall the given word. And for the visual perception, you can see here the worksheet. You will ask them to recognize item as much as they can, and the time is within 1 minute. If they couldn't able to name it, example, the patient could not name a key, so at least they are able to point at the object here. They can figure it. And then for the naming, it's a little bit different. And for the attention, it looks quite different. So you will ask the patient to say certain number according to the given instruction. Yeah, so here is the different. I didn't repeat myself for the orientation. It's almost the same. And here is the Arabic version. And here there is a trial. I and Dr. Roa tried to make a video for you. I hope it helped you to look at the test and how we can administer it and find if there is a mistake or no. Is the sound clear?
No, there's no sound.
Really? Okay. I try to increase it, but again,
Uh,
okay.
yeah, there's no sound.
So I will say what I was saying to Dr. Roa. So I was telling Dr. Roa to draw a line going from a number to a letter in ascending order. But you can see her performance. She started by number A, and then she went to a letter A, but then she confused. And then I prompted her. This prompt, I want you to think about it and tell me um, um, what I have done is appropriate or not appropriate. You can share your responses in the chat. Dr. Roa, if you are able to read the chat.
Yes, sure. So nothing yet, no responses yet.
Okay. Okay. So what I have done with her, I should allow Dr. Roa to do all the trial until she finish. She may have a space to correct herself, because if she corrected herself, that's considered a correct response. If she moved to the other task, which is the cube design, and she did not correct herself, that's considered a wrong responses. And here another trial. Again, I asked Dr. Roa to copy this draw as accurate as she can. So her response here considered appropriate. She make the design, even if there is like if the cubes is presented as a square and she draw it as a rectangle, it's considered accurate. The matter is the line and the dimension. And here for the draw clock, I asked her to draw a clock, and I asked her to set the time 10 past 11. So what do you consider the draw here? Is it appropriate, correct, or not correct? So the problem here is when she placed the numbers, she placed some of it inside the contour and some of it out of the contour. So this is considered as wrong. However, they are correct. She placed it from 1 to 12. And here, back to Dr. Roa, she will talk about the other assessment tools. Thank you.
Okay, thank you so much, Ms. Saad. This was very elaborative. Now, as we mentioned, and as you mentioned, these are just screening tools, but they're very important. I just want to remind everyone that the illustration of MOCA is available on their website, the instruction sheet. Now, a couple of years ago, they started to mandate having a certificate. So you need to purchase the training online, attend the training. You have a certificate that you're certified to use MOCA, and then you can use it in your clinical practice. But because they don't have a workshop for Arabic, you can go to the website and consent and acknowledge that you will be back to take the course in Arabic once it's available, and they will allow you to download the instruction sheet and the MOCA itself. So to answer a previous question, someone was asking about those who have a low level of education or illiterate. It's tricky, it's hard, but as Dr. Modi mentioned, the population is changing. This is probably not going to be a concern 10 years from now, but for the time being, MMSC and MOCA-B are good options, and the mini-cog with all of its limitations. Now, a very important part of assessment is to assess functional status. So it does not really matter how much the patient scores on MMSE. If this patient is unable to pay their own bills, if they are unable to take care of themselves, if they are unable to use their own cell phones, and this is how we assess functional status. We mentioned earlier that the amyloid targeting antibodies are only given to those who have mild cognitive impairment and mild dementia. And these are the tools that we use to distinguish those different stages of the disease. So when we talk about activities of daily living, we talk about instrumental activities like driving, taking their medications, financial management, paying bills, using ATM cards, preparing meals, shopping, or basic like dressing, toileting, bathing, and eating. They can be independent, they may need some prompting, they may need some assistant, or they can be fully dependent in everything. Now, there are so many cognitive assessment tools. As I mentioned before, CATS is one, Bristol Activities of Daily Living is one, Lawton. It does not really matter what functional assessment tools you're using, as long as you know what you're assessing with this functional assessment tool. As I mentioned, CATS really assesses only basic activities of daily living, and it does not assess instrumental activities of daily living. Can you go next? So Bristol Activities of Daily Living is validated in Arabic. It was validated in Saudi Arabia by Dr. Walid Al-Kredi and his group. It's available in the Ministry of Health website on Shaham for those who work in Ministry of Health. And the paper is available online. If you write Bristol Activities of Daily Living Arabic validation, you can find it for Dr. Walid Al-Kredi. So as you can see here, we're asking about some basic activities of daily living like bathing and hygiene and cleaning their teeth and taking shower. But we're also asking about like managing their bills, their finances, transportation, driving. So I really encourage you, if you're going to use a functional assessment tool, because this one is already translated and validated in our population, I would really encourage you to use this tool. The other tool that I would really like to emphasize on is the clinical dementia rating scale. The reason why I would like to emphasize on this one is because it's used in most of the trials for the amyloid targeting antibodies. It is actually a lengthy tool. The Bristol is a questionnaire that you can give to the caregiver to fill, but CDR is an assessment that you as a healthcare provider do in the clinic. So you need to sit first with the caregiver, take some history. If you Google it online, it's available, and there is an available training for free on their website. So it's a little bit lengthy. I would say you would need like 20, 25 minutes to finish it. But it's worth investing in it and learning it because it's one of the primary and sometimes secondary endpoints in clinical trials when it comes to dementia. So basically, after you go over the tool, you ask the questions and you write down your answers. You kind of make your own impression at the end about every cognitive domain. So based on what you've heard from the caregiver and what you've asked the patient and they answered, you decide that memory is questionably impaired, mildly impaired, moderate, or severe. And then to calculate the global dementia rating, clinical dementia rating scale, there is a specific calculation, but if you go online and write CDR calculator, you can just log in your findings and get the calculation. But if you want to be more detailed with CDR sum of boxes, you can just add the boxes and sum them and find the total score. Now, a score of 0 is normal. A score of 3 is severe dementia. 0.5 is MCI versus because MCI usually they don't have impairment, we say very mild dementia. One is mild dementia and two is severe. Next, please. So this is the sub-score, like the sum of boxes, where 0 is normal, 16 to 18 is severe, and in between you have different ranges um, of assessment. Okay, I think we're done with this part. Do you have any questions? I think I saw a question earlier. Let me just make sure. So sorry, دقيقة. So my question is about the MOCA itself. In fluency, the letter fa is a bit difficult to find words, not nouns. Also, the language part, the sentences used seem difficult. So, Ms. Suad, do you have any comments on this? About
Yeah, as you,
fa,
yeah,
there's an alternative letter.
there is, if you find the patient is struggling with the verbal fluency task, I haven't like seen any other Arabic translation, you know. We just have the one with the fa letter. However, as you mentioned earlier, it is not validated in the Arabic or in the Saudi mainly norm. So we don't have other version. But for you, if you want like to rule out if the patient functioning within average or no, you can go with a further assessment. There is an Arabic verbal fluency assessment called Waraq for Dr. Muhammad Salah. So you can go with the semantic and the initial letter, and you can assess your patient, and from there you can tell if the patient functioning within average or no. Plus, sometimes the score will presented within average, but you have an indication. So, example, the verbal fluency, the patient maybe did not function well or did not do well, or in the memory task, you have to go, as we mentioned earlier, further assessment will navigate you where where is the patient or what's the patient doing.
Yeah. Well, yes, this is very helpful and very excellent suggestion to use. Like you cannot really change the test because this is how it was developed, unless you're going to change it and then validate it. But yes, doing more testing in the domain that you're suspecting is very helpful. Now, regarding the sentences, in the normative study that was done in Riyadh, they looked at they did not change the sentences, but they changed some of the semantic. So, for example, أبو نسيب زار جاره واطمأن عن صحته. They changed it to على صحته, and this is what I do in the clinic. So I say على صحته instead of عن صحته. Well, thank you very much. Thank you, Dr. Ms. Suad. This was very great and helpful. The details you've mentioned are excellent, especially in the pitfalls in MOCA assessment. Now, I know that we're coming to an end. We promised to have some case discussions, so I'll go over them quickly. But I would appreciate if you can do the post-test now. I think it's meanwhile, while I'm pulling my presentation, I would appreciate if you fill in the post-test. And I would really appreciate suggestions on how to make these workshops better and on what you would like to see in future workshops. That's going to be very helpful to us. طيب. So I shared the link for the post-test in the chat. I hope you will have the chance to do it. I'll go over two cases quickly. If you remember in my talk earlier, we talked about 3 questions to answer. So we need to know the cognitive function, which we've gone through with Ms. Suad and myself in the previous presentation. What's the behavioral syndrome that they're coming with, and what is the most likely underlying pathology? Now let's go to this first case. This is a 73-year-old woman who's coming with 3 years progressive memory loss. Her husband reported that she frequently misplaced personal items, forget passwords, repeats the same question, trouble locating her car in the parking, and had been late paying bills. She had difficulty completing tasks and recently seemed overwhelmed when trying to plan travel for vacation. She had shown less interest in previous hobbies, but did not report low mood. She denied motor problems or disruption of sleep. Her husband had taken over managing finances and bill paying and had to remind her to take her medications. She was otherwise independent. Her past medical history was notable for long-standing hypertension, diabetes, and dyslipidemia, and she had an episode of delirium 5 years ago. So if we try to answer these questions, review of medications did not reveal any substances that are affecting cognition. Family history notable for late onset dementia. And she had 16 years of formal education. She rarely drank alcohol, no smoking. During the interview, she had difficulty describing her symptoms, often deferred to her husband to answer questions. This is a very common sign in people with dementia. When you ask them, they look at their companion, asking for help or deferring the questions to them. Her recall of recent events and public events was impaired. She lacked details in the events, and her insight was limited. She was not aware that she had problems. On cognitive assessment, she scored 22 out of 30 on MMSE. She lost points for orientation, recall, and serial sevens. She showed moderate impairment on tests of verbal and visual memory, mild deficits on tests of executive language and visuospatial function. So mostly orientation and memory with some attention. The rest of her neurological exam was normal, labs were normal. Brain MRI showed atrophy of the hippocampi and medial temporal lobes bilaterally, mild atrophy of the lateral temporal and parietal lobes, and no significant vascular lesions. So can we answer those three questions? So let's dissect the case. So if you look here, you see some features of memory problems, misplacing items, forgetting passwords, repeating questions, and you see some visuospatial symptoms like locating her car. She has some executive dysfunctioning in the form of not paying her bills on time, difficulty completing tasks. She seems overwhelmed when trying to plan for travel. And you can see that there is evidence of functional decline. Her husband has taken over managing finances. So you can see that the most striking and the thing that brought them to the clinic is really memory, and this is how it started. And you can see that there is evidence of functional decline. So this is beyond just mild cognitive impairment. So there is family history of late onset dementia. She had difficulty describing her symptoms. So on exam, you can see that she did have some troubles. So her lab evaluation, as I mentioned, did not reveal anything. So the patient was diagnosed with dementia due to probable Alzheimer's disease and was started on acetylcholinesterase inhibitors. Now she was reported to the motor vehicle department to reassess her driving and see if there are any issues with her driving. So she had mild, I would say mild dementia, probably moderate, because you can see that she has significant decline, like she's unable to take her medications, her husband took over her finances. It's more than just mild cognitive impairment. It's mostly amnestic, and the underlying pathology is AD because of the atrophy that we've seen. So if her CDR was found to be 2, that would be more consistent with moderate dementia. So if we have the same patient but was still able to do all ADLs and CDR is 0, at that point we would say this patient has MCI, because this patient is abnormal in testing. They do have symptoms, but they are completely independent in their ADLs. Would you consider immune therapy? Well, that's a question that I would leave to you. Now, the other case is a 69-year-old female who has hypertension, dyslipidemia. She came in July 2019 because her family noticed that she became forgetful. Again, she forgets appointments, name of people. She has significant difficulty planning. She makes a lot of wrong decisions, difficulty solving problems. She has attention problems, difficulty concentrating. She gets overwhelmed very easily if someone speaks too fast to her. She has no language or behavioral issues, and the problem started insidious and worsened gradually over time. No psychiatric issues, and she's independent in all of her ADLs. Okay, I'll go to the cognitive assessment. So she scored 20 out of 30 on MMSE. She missed 2 points in orientation to time, 1 in orientation to place, 5 in attention, 1 in recall, and 1 in repetition, 1 in writing. She was very inattentive, unable to count backward. She was fluent, able to repeat sentences, but was not able to write a sentence correctly. She was able to register 5 words, and she was then later unable to remember any of them. Now, I just want to show you this. So when she was asked to do because I could see that she had a lot of attentional problems. So I was thinking, could this be executive dysfunction versus attention? So is this really a memory issue or not? So I asked her to draw this pattern, and as you can see here, she was drawing it. She's supposed to draw 3 loops, but she continued drawing several loops. If you can look here at المستشفى التخصصي, she wrote حرف الشين maybe 4 times, حرف التاء maybe 4 times. So that's what we call perseveration, and it's very common with frontal lobe disorders, executive dysfunction disorders. Again, when I asked her to draw the clock, she put the hands wrong. She did not complete it. A lot of attentional issues. She realized she had a problem. It was not clear. But then when she tried to draw it again, she drew the same clock. So that's another sign of perseveration. So you can see that she has some episodic memory issues, but she also has a lot of attention working memory executive dysfunction issues with perseveration on multiple sequencing and writing. And in the clock drawing, again, she had evidence of perseveration. Her MRI was showing evidence of small vessel disease, and she was diagnosed to have a vascular cognitive impairment. Okay, so thank you so much. I intentionally went quickly over the last slides because we're running out of time. I hope this was helpful, and I hope that you were able to do the post test. It's really very essential to us to help us make better workshops next time. I would like to thank my fellow speakers, Dr. Lubna, Dr. Moudi, Ms. Suad. Without their help, this couldn't have been done. And very special thanks to the chapter for their support. Special thanks to Ms. Wiam. Ms. Wiam is always the hidden soldier of all of these activities. And of course, to our organizing company, Mr. Sameh, thank you for your help. And to you guys for hanging on until the last minute. Thank you so much for being still here. And all of your feedback and comments and everything you say is really appreciated. Thank you so much. And I hope we can see you in the future in next future workshops. You can follow the Saudi Neurology Society account on Twitter, and you can follow the Saudi Cognitive and Behavioral Neurology account on Twitter for the future announcements. You can also follow me on LinkedIn for all of the future announcements for our workshops. We still have a lot to come, and inshallah, together we're going to make Alzheimer's world better, inshallah, بإذن الله. Thank you so much.